I just wanted to thank Dr. Porterfield for the opportunity to talk today. Also, this is a fantastic panel of both surgeons and educators. I'm genuinely humbled to be here to talk a little bit about what happens sort of after training, making that transition to practice, and some of the things I've learned, and some of the ways that I wish when I was a resident potentially could have been more involved to get me prepared to start a robotic program. Um, I'm pushing the wrong button. Okay, here we go. Sorry. So for Intuitive, I do observation sites, proctoring. I'm also speaking engagements, and I just really enjoyed that talk by Dr. Augustine about the importance of being knowledgeable about this, because again, that's something I wasn't prepared for coming out of residency. As an aside, though, I had an opportunity to have a heated discussion with, this is Dr. Alex Rains at the University of Oklahoma, who's a true robotic champion. And after a day of surgery and a couple beverages, we talked about the value of disclosures and what you can do with some of that money. And together came up with this idea of the proclaimers. So while I do accept funds for the time for industry, I also now take a portion of that money and donate it to different organizations that my family and I decide on, because it takes time away from my family. So my daughters are Girl Scouts. For a little while, my son wanted to be a fireman. He's 4. So these are some of the things that we've been able to help and benefit. So just a sort of different take on that relationship. But now getting back to it, I think as Dr. Zhang really mentioned very well, the robotics has had a lot of different connotations and sort of definitely creates mixed emotions. And when you're trying to start a program, particularly as a new attending in a new environment, you run into a lot of hurdles. Because a lot of people, sometimes patients, sometimes people on the OR staff think of it as a helpful robot that makes you do better surgery, but oftentimes they think of it as an angry robot that steals your operative time, your money, and your open surgical skills. So really breaking through these boundaries has been a really difficult thing. Particularly starting, again, I think residency does a great job of teaching you how to be a surgeon, but not necessarily preparing you for sort of the different landscape that is the medical field nowadays. When you want to get out there, you really need to be oftentimes a robotic champion, just not a robotic surgeon. You're going to be the one at the institution that sort of changes it from 2 cases a day, steep Trendelenburg, anesthesia hates it, the nursing staff hates it. So how do you do that? How do you get comfortable breaking through the institutional inertia? So many times at my institution when we tried to make these changes, the answer was no, not for any reason other than that's just not how we do it. So getting through that, getting through the myths, getting through the fear of robotics, which is great. I mean, honestly, it is challenging. You're a new attending in a new market, potentially with established referral patterns, and you've got to make these changes. How do you do it? And the answer so far has been education. In 2.5 years, I spent a lot of time talking to literally anyone and anyone that would listen about the benefits of robotic surgery and why I think it's important for me to practice as minimally invasively as I can for my general surgery practices. And the roadblocks I've run into, this is just a short list, have been substantial and across multiple different areas. Starting with the robotic steering committee at my hospital, that when I got there, the only cases from a general surgery standpoint that were allowed were ventrals. I couldn't do an inguinal, I couldn't do a foregut case because they didn't see the value in it. My office staff, Roseanne, who answers my phone, for the first 3 months, I'm pretty sure she thought the robot did the surgery. So getting her on board with robotic surgery, obviously very important. Primary care providers, again, in my area, most hernias are done open, so they would tell patients only to get their hernias fixed if they were incarcerated and need to go to the ER. And then in terms of getting efficient and getting better at operative times, shortening time between cases, sterile processing and anesthesia, things I had very little concern of as a resident, became much more important. So part of it is explaining the benefits of robotics to people that don't operate, because I have to do this a lot. So this is one of the ways that I came up with to talk about the benefits of the visualization. Because a lot of people don't understand the difference between a 30 scope, a 5 scope, a 10 millimeter scope. So how do you explain why it's important? So I tell them if I was going to go to a football game and I wanted to watch the quarterback, I would get binoculars, right? I would zoom in on what I want to see. Laparoscopy asks you to do that same thing, but you give the binoculars to the person sitting next to you, which doesn't make any sense, right? So inevitably, in every laparoscopic case, what you want to see is slightly to the corner and a little bit blurry. And if you wait 10 or 12 minutes, it's always crooked, right? So for them, that makes sense. This is why I do robotics, because I have complete control of the camera every time. I see exactly what I want to see. And it's not a quarterback. For me, I do inguinal hernias. It's the myopectineal orifice. There's actually a part of this surgery called the triangle of doom. And it's important to stay out of that. So for me, to see that layer of peritoneum as I'm rolling it back is unbelievably important. So again, a different way to communicate. And part of what I'm going through here is I really want residents to get better at communicating about what they do and why it's important. Looking back on my residency, the only time I really got to talk about what I was doing was at M&M, which is a totally different paradigm. But now you're asked as a new attending to stand in front of a group of people, potentially hospital administrators, potentially CEOs, and talk about why what you're doing is important. And it's a steep hurdle to climb. The other thing I really emphasize is collecting your data. So obviously there's some great studies coming out about the importance of robotics, but even at a community hospital like mine, we do a good job of collecting our data and looking at the outcomes. So this is actually 802 because I did 5 cases. I had an add-on on Tuesday. But in 2.5 years, we've done a good number of cases. Sometimes I get access to both robots, so we bounce back and forth for 8 cases in a day, 17 a week. And again, this is the same hospital system that before me was lucky to get through 2 cases before 6 o'clock. And then what we did was we tracked the outcomes from these cases. So as you can see, my case mix is essentially hernias all the way to full component separations. Pretty much anything I can do minimally invasively, I'll try to because I think it benefits the patients. But what I did is I looked at my length of stay to the same procedures done at the hospital, my same hospital the year before I got there. So the bulk of these cases were done open, some were done lap, but you can see that ventrals mine stay 0.2 days. I've had one inguinal hernia stay overnight because he was 97 and anesthesia didn't want him to go home. But the bigger, more complicated cases, certainly there's a significant length of stay. So collecting your data, again, understanding your value is important. And as you guys go through your learning curve, if you're already there, I encourage you to have your residents go through this because it's something that I wish I knew and was better at in the beginning, sort of had to catch up at this point in my career. But really diligent now about it. And there's been nothing more important than the data that's really moved our program forward because it really does expand on the benefits. So those 800 cases, when you total that together, has saved my hospital administrators 1,100 days in the hospital. So obviously you can put a value to that, but really what it does, the patients have done better. Knock on wood, I haven't had a conversion yet. I know it's coming. We haven't had any surgical site infections. So when I talk about the benefits of a minimally invasive approach, those are the things that I highlight. But again, it really comes back to doing surgery the best way you know how to do. So one of the big arguments I had with my administrators was we weren't allowed to do robotic cases at night. Because it really comes down, ultimately, all of this to the benefits. And the question about how you make your residents or how you prepare them for robotic surgery is to do exactly what you're doing now. It's the same way that you prepare them to be good laparoscopic surgeons and open surgeons, to make them good surgeons. I'm learning to be a better surgeon because of the people that trained me, both in residency and fellowship, and I'm indebted to them for getting me to this point. But it is an opportunity to get them more exposure, more opportunities to discuss some of the building blocks for building a practice and getting a robotic curriculum going. These are 2 of my first cases, my first component separation and a paraesophageal I did on a 91-year-old female who everyone was afraid to touch in my institution before I got there. Scary cases as the 16th and 18th cases in your surgical career. But again, I was fortunate to have good training and get through them. They both did very well. And this is a patient who did sign a disclosure to be in my talk, which is, I realize now is important. But he's the first emergency case we did on the robot. He had bilateral open hernias 25 years before he got to me. They were so painful that he neglected his recurrence until Sunday morning at about 3 o'clock. So it just happened on that day that my robotic team was on call. So I made 13 phone calls to different administrators, and they let me do his hernia robotically, the same way I'd done 6 other ones that week. He did great, was discharged the same day. This is him in his post-op visit. The day following, on Monday morning, I got 13 more phone calls explaining to me that we could never do that again because we don't have a robotic protocol in place. My hospital doesn't have an open protocol on the weekends or a laparoscopic one, but that didn't seem to matter to anybody. And unfortunately, it took 7 months of meetings, again, none of which I was prepared for through my residency, to talk about why we needed to get this done and to get nurses trained and staff trained. But now I'm proud to say we can do robotic cases at night and on the weekends, because the care you give your patients, I don't think, should be delineated by the time of day or the day of the week. But again, I'm indebted to all of the educators out here. It's really been an amazing journey through training and through starting a program. And I think the opportunities really are to encourage your residents to participate in the programs at your building, particularly the ones that are enthusiastic about it and may want to sort of take it as they move forward. But then also just get them used to communicating, not just communicating to you, but communicating to other people in the hospital system. Take them to your meetings, get them comfortable talking about the value of what they're doing across any specialty and why they think it's important. But seriously, thank you guys very much for your time.